Distinct selfie.
Oh, it is. Okay. There it's.
Let's go.
Oh, okay. So I'm Dr. Boddu. I'm neurointerventionalist. I would say Dr. Prashanda, they are the minds of the stroke program, and we are the muzzle of the stroke program. And there's a massive effort. And Dr. Prashanda, he is the site director, and the numbers, the increase in the numbers, you can see that's how very well it's being performed now. So if we go into my talk, so the goal of ischemic stroke treatment is to restore the blood supply back to the brain. So when you call a stroke, there is basically a blockage in the blood vessel, and it is stopping the blood going to the brain. And your purpose of the treatment is to restore the flow back to the brain. If you stop the blood flow, then brain is losing its oxygen, its food, its nutrients, so it is going to stroke out, and which is going to leave a permanent deficit. So the purpose is to make it from there to that point. So here you can see this is called a angiogram, where you inject the dye into the blood vessels, and you see where is the blockage in the blood vessels. Here you can see there is a blockage, and once you take out the blockage, and this is how the blood flow goes back to the brain. So once the blood flow is restored, the brain damage is stopped at that point. Why it is important to restore the blood supply to the brain? Because based on multiple studies and trials, we know if you restore the blood supply to the brain as soon as possible, the time is essential. So as soon as possible, if you restore the blood supply, then there is a very good chance of a better outcome. Patient can be independent, and also the chance of a mortality, the death, is very low compared to the not leaving the patient without treatment. You all know time is very essential in this treatment, and the brain is time here. And like we were talking by Dr. Prashanda, he explained there is a clot bursting medication given to these patients as a first line of treatment. And so far, that is the gold standard treatment for the stroke. But then comes the question, why mechanical thrombectomy? The mechanical thrombectomy means going in and pulling the clot out. So you are relieving the blockage. So if the clot bursting medication is doing that job, why do we need to go in to pull the clot out? The answer is clot bursting medication when it is blocking the main blood vessels. So everyone has two main blood vessels supplying to the front of your brain, and two main blood vessels that supplies to the back of your brain. So these are the main blood vessels, and once they go up, they divide into branches. So if there is any blockage in the main blood vessels, your chance of reopening that blockage just with clot bursting medication is 6%. So it is very low. So that is the reason you have to go in and pull the clot out as soon as you can. But when you give the clot bursting medication, it is saving you the time, and it is just acting till you are going and pulling the clot out. It is still working during the time. And also, if you don't pull the clot out, when the blockage is in these main blood vessels, and if you don't pull the clot out, if it is in the front of in the front of your brain, the blockage is, there is half of the patients are going to die. And if it is in the back of your brain, where all the important, your centers that controls your respiration, controls your heart rate, that is a more crucial area. If there is a blockage and you fail to open that blockage, 90% of them are going to die, they say. So that is the reason you had to open the blockage as soon as possible. So what is the mechanical thrombectomy? So basically, you are going to put a small needle in the top of your leg. It does not need any cuts, no stitches. It's basically a needle that goes in. It's essentially the same needle as your IV line. When you go to the hospital, they give you the IV fluids. It's the same line, and it goes into the groin. And through that thing, a long catheter that is something like a spaghetti that goes up under the X-ray guidance that goes all the way into the brain. And in the brain, once we reach to the site where the blockage is, we are going to use a stent. That is the one we've been circulating. These are the stents. Depending on the size of the blood vessel, we choose the size of the stent. And we put this into the clot. You wait for 3 to 5 minutes. So the clot just comes and sits in the stent, and then you pull the clot out. So these are the ones. Okay? And this is the blood supply to your brain. Like I said, that there are two main blood vessels that goes to the front of your head. Those are called carotid arteries. And two blood vessels that goes to the back of your head. Those are called vertebral arteries. In the back of the... Say again?
What are they called? The back
vertebral arteries. The vertebral bodies, because they travel through them, these are called VERTEBRAL. And both the vertebral arteries combine to form a single main artery called basilar artery. So if there is an occlusion in the back of your head, that's a one blood vessel going to supply the whole area, and the outcome is going to be very poor. So it has to come out quicker. So what are we trying to achieve in this treatment is whenever there is a blockage, like Dr. Vishananda was mentioning, every minute it's a 1.9 million neurons are dying. So the moment it blocks, it doesn't matter how quick you come to the hospital, still there is a small area of a stroke, a very small area of a stroke. But we are not interested in that one. So if you look at this area, so the main thing here is the stroke, that is there is nothing we can do about it, but there is a large area of a penumbra, which means that area is in shock. It is not damaged, it is not dead. The core infarct is a dead, there is nothing coming back. But the penumbra is an area in shock. If you open the blood supply, all that area can live. So that is the area we are trying to address. So you go in and you pull the clot out, there is a large area that is at risk. You stop that area from getting damaged completely. So suppose, and what happens, it's when there is a blockage here, suppose this is one of the blood vessels that called as a middle cerebral artery, and this is an anterior cerebral artery. When there is a blockage here, brain tries to help you and give you some time by asking the friends. So the blood vessels next to the blockage will try to help you. So till certain point they say, okay, we are going to give you some oxygen, we are going to give you some blood supply, but that is only a short acting. So that is the time where you need to go in and open the blood supply from the blockage so that that actual supply is restored. So you can see something, so going back to the how we are the stent retrievers, the ones that we passed to you are called stent retrievers. These are the devices that goes into the brain and we pull the clot out, and these are actually started from 2012. It's not that long ago, 6 years back these started. And so basically what we do is you go to the blood vessel and you can see there is a blockage on the top of the blood vessel there, and top of the blood vessel, and once you go there you put the stent, you put this stent into the clot and you wait for 3 to 5 minutes, and the clot comes in and gets trapped into the stent, and you pull the stent out. And sometimes when we are pulling the stent, some of the clots gets broken out and then goes out and causes smaller strokes. So what we are doing now is when you are pulling the clot out, you are connecting the tube to the suction. So nothing is going out distally. So as soon as we are pulling the clot out, and we are aspirating the small blood clots as well. So that gives you a better outcome for these patients. And again, this is to highlight the time is essence. So we are monitored very strictly. We are under continuous scrutiny by the Joint Commission. So basically, once the patient comes to the emergency room, it is within 10 minutes, the CAT scan should be done. And once we decide it's a patient is a stroke, from the time patient enters into the emergency room, we should take the patient for treatment within 90 minutes. And from the time we start the treatment, within half an hour, patient should be treated. So basically, from the time patient touches the emergency room door, within 2 hours, the clot should be out of the patient. That is a very strict criteria, and that is where all the time sense comes into this. Because we know by evidence now, if it is the sooner you open the clot, sooner you restore the blood flow, the greater is outcome. And here are some of our patients. Here you can see the dense spot. There's a bright spot. That is the blood clot. That is a fresh blood clot. That's how it looks on the CAT scan. When you do the CT scan, if you see that one, that is a blood clot sitting there. And you can see this is the patient, when you do an angiogram, and that blood clot corresponds to this blockage, and patient had a stent, and the clot was pulled out, and this is the blood clot that was pulled out through the stent. So patient immediately, most of the times we try to keep it, depending on how the patient is doing, we keep the patient under general anesthesia, pull the clot out and waken them up. Otherwise, if the patient is reasonable and talking, then we just keep the patient, keep him distracted, go up and pull the clot out. And it's the same situation here. There is again another blockage where your arrow is showing up, and there is a stent, the same stent we passed across. You can see that stent deployed in the blood vessel, and after the stent is deployed, the blood flow is partially restored, and you pull the clot out, that is complete blood flow. So patient gone from here to that one, that is a complete blood flow restoration. And this is in the back of your head. So you should have had the same blood vessel going like this. There should be a blood vessel on this side as well. So when there is a blockage of the blood vessel, and you put the stent across and wait for 3 to 5 minutes, and you can see the partially restored blood flow, and you pull the stent out and the blood flow is restored on this patient. And even worse, both the blood vessels are gone in the next patient, and stent, and it's a complete restoration of the blood flow. And sometimes it's also, we look at when we do an angiogram, these patients, when a patient had a stroke, that means he has a risk factor, vascular risk factors to develop other issues, like the other issues including aneurysms, which can cause bleeding into the head. And this is one of the patients who had a stroke, and you went up to treat the stroke, and we found an aneurysm, and he survived the stroke successfully, and then we went on to treat his aneurysm as well. So there's one, forget about all these things, a simple take-home message from both of our talks is time is essence in the stroke treatment, and with going in and pulling the clot out has much better outcome in terms of how patients are doing and the less chances of dying. And these patients are more independent compared to just leaving the patients hoping they will get better. Okay? And important, you have to identify the signs of the stroke, act fast, and this major treatment is now just available across here. It is 10 minutes across. I can tell you a story on this one, and this is the mobile stroke unit, and this is the biplane suite here. This is where the treatment room performed, and that's me. And I can tell you the importance of why I'm stressing the importance of this treatment being here. Me and Dr. Pishananda, we both did fellowship at Cornell. We both were pretty much in the same batch. Of course, I'm older than him. In a year before we started the stroke treatment here, whenever a stroke patient comes to the Queen's Hospital, we used to transfer him to Cornell and treat them. You all know, living in New York, if the patient has to be transferred from Queens to Cornell, it takes roughly 2 hours, at least 2 hours. In a year, we transferred 40 patients from Queens to Cornell. So all of those 40 patients would have done extremely good if they had a treatment here. But by the time they gone from here to Cornell, it took 2 hours at least, and most of them had severe brain injury, like most of the brain is already stroked out. And how many patients were benefited out of 40? 4. So 36 patients. So that is the importance of the time. And that is what makes it massive impact of this service being here. And mobile stroke unit just coming as soon as 911 is being called. I mean, we can develop the infrastructure, but ultimately it's the patients and the families that are calling 911 that makes this difference. Oh, these are the clots we pulled out in multiple patients. So each patient is different. There are different clots.
Cool.
Questions? Sorry.
You said that because you close by instead of Cornell, but